Okay, so we're going to continue our discussion of the functional anatomy, this time looking at the spinal cord and the tracts within the spinal cord leading to the peripheral nerves. So the spinal cord is an elongation of nerves that are distending from the brainstem down through the vertebrae, ending at what's referred to as the cauda equina. Many of the axons of the nerves within the spinal cord are going to have their origins within the pyramidal region of the brainstem. That's the region just around where the cranial nerves are going to be originating. We have two distinct enlargements within the spinal cord. These are in the cervical region and the lumbar region. The cervical enlargement and the lumbar enlargement is what leads to the peripheral plexes, and it's the peripheral plexus of the cervical region that's going to lead to the nerves of the upper extremity, and then the lumbar plexus is going to lead to the nerves of the lower extremity. So when we look at the spinal cord, we break it up into regions such as the central canal, the hole in the very middle, the gray area, which is the wing structure in the center, and then the peripheral white matter, which is the area outside of it. We further break this into two distinct areas. The two distinct areas are basically divided in terms of a dorsal and a ventral side. The dorsal side is primarily going to be afferent fibers, whereas the ventral side is going to be primarily efferent fibers. Now, we have to remember this orientation as we look at the next image that I've drawn for you, as relates to sensory input and motor output and what's referred to as the ganglion distribution. So here is a cross-sectional diagram looking at the spinal cord, where we have the sensory input coming in red, coming along the dorsal pathway, where the cell bodies of these neurons are going to be found within the dorsal root ganglion, indicated as number 6 in the diagram, heading to the dorsal horn, indicated by the red star, where it's going to synapse with the interneuron, at which point in time the ascending track can begin, or I can go ahead and develop a reflexive arc to the blue star, where we're going to have the lower motor neurons originating within the ventral horn as well as the lateral horn, indicated as numbers 10 and 11 on the image. These are going to lead to the motor neurons. The motor neurons are going to have one of two pathways out. Either they're going to head to the motor neuron heading out to the skeletal muscles, allowing for the skeletal muscle to contract, or it's going to head into the sympathetic trunk or out into the parasympathetic ganglion. The parasympathetic ganglion will also traverse along the pathway where it says motor output. What these nerves entering and exiting the spinal cord do is develop what's referred to as the nerve roots. The nerve roots is what is going to allow for us to distinguish where a specific nerve is going to originate within the spinal cord. We indicate the nerve roots based off of the region, such as if it's coming from a cervical, it would be the cervical nerves. In this case here, there are 8 cervical nerves. If it's coming from the thoracic, we indicate them as being thoracic nerves. In this case here, there are 12 thoracic nerves. If it's coming from the lumbar region, we indicate them as lumbar nerves. In this case here, there are 5 lumbar. If we indicate them as coming from the sacrum, we refer to them as sacral nerves, and once again, there are 5 sacral. If it comes from the coccygeal region, we refer to them as the coccygeal nerves, and there are 2 coccygeals. The number of nerves, except for the cervical region, is an indication of the number of vertebrae within that. The nerve itself is going to pass inferior in the thoracic, lumbar, sacral, and coccygeal through the intervertebral arch, where the pedicle and the lamina of the vertebrae in between the facets, and is then going to traverse out into the periphery from there, forming the peripheral nervous system. The exception comes in with the cervical. In the cervical, what ends up happening is that the nerve is actually going to exit superior. So it's going to exit in the superior arch in between the vertebrae. That's how we end up having the 8 cervical nerves as opposed to having the 7 cervical nerves, because there are only 7 cervical vertebrae. Now, I'm going to get here in a second with the myotome and dermatome map. If there is injury to the spinal cord, we can actually indicate where that injury happens to be in the spinal cord based off of the deficits along that specific nerve root. The injury to the spinal cord, if it happens between C1 and C3, usually leads to death for the person. There are a couple of exceptions, and I'll give bonus points to whoever can email me the name of at least one person who survived a C1, C2 cervical injury. The reason for this is because the nerve that's going to help regulate ventilation passes through that region, and we'll look at that when we look at the peripheral nerves. Now, the other thing to note is that once we get to the L2, L3 region of the lumbar, the structure that we looked at previously as relates to the spinal cord starts to break apart, and we get nerve roots coming out of that. It forms a structure known as the cauda equina. It's this region of the spinal cord that we can actually go ahead and enter into the dura mater in order to extract cerebrospinal fluid. In fact, that's the region where we go about doing spinal punctures, doing spinal taps, and doing epidurals, for those of you who've ever had to do an epidural for birthing. So if we look at the dermatome and myotome map, what we end up getting is we end up getting an overlay of where the nerve root coming away from the spinal cord happens to map out on the body. Now, if you notice, within the thorax, it's nice rings. Those nice rings is an indication of where the vertebrae are in relationship to the nerve as it exits. Now, if you notice, within the upper extremity and within the lower extremity, there's this spiraling. I'm going to post onto the Google folder for narrated presentations a video of the fetal development that helps explain why the map happens the way the map happens. It has to do with what happens to the upper extremity and the lower extremity during limb budding that causes that spiraling to take place within the upper extremity and the lower extremity. But what we're able to do with the myotome and the dermatome map is we're able to map out where we get motor function, myotome, and where we get sensory function, dermatome. Now notice there's a part of the body that does not have a map on it. That happens to be the facial region. And the reason for that is because of which spinal tracts are responsible for controlling the sensory input within the face, as well as the motor affect within the face. And we'll take care of that within the next presentation when we look at the spinal tracts as relates to motor and sensory function.